Welcome to the second day of the Asia-Pacific HIV Clinical Forum. So again, this is the first time that we, host a virtual meeting. For those of you might not attend the first day of the forum. So let me introduce myself briefly. So my name is Kiat Ruxrungtham. I'm a professor of medicine at Chulalongkorn University. And I'd like to also briefly introduce my program co-chairs, Jonathan Shapiro and Charles Boucher. Myself is a local chair. Again, let me go through this goal and objectives for those didn't attend the first day forum. So I think this forum is clearly that our goal is to improve our clinical care for people living with HIV. So we're going to update the audience about the clinical utility of integrase inhibitor in HIV treatment and update the latest research data in the field. And we'll cover also the implementation of PrEP and the issue to understand the prevention strategy in this region. So today is the second day. We will start the session 3 after this introduction. Please submit your question during the session so we can have our speaker to address your question. Here are, again, to introduce our international faculty member, all well-known in the field, so both locally and regionally and globally. So I hope you're going to enjoy all the talk, both you have enjoyed yesterday and today to next sessions. On behalf of our co-chairs and organizing committee, I'd like to thank to VIP Healthcare for the support. So now let's be welcome to this session 3. This session we're going to focus on subtypes, gender, and ethnicity to the impact our HIV care. So we have 3 distinguished speakers, Professor Opass Putcharoen, Professor David Beck, and Professor Mark Nelson. Let me start by introduce our first speaker. So Opass is the infectious disease doctor at the Department of Medicine, Faculty of Medicine at Chulalongkorn University. He also the director of the Clinical Emergence Infectious Disease. So I like to welcome Dr. Opass to give a talk on HIV subtype, virologic and resistant implication. So the floor is yours, Dr. Opass, please.
Thank you for having me today. Today I'm going to talk about HIV subtype, virologic and resistant applications. This is my disclosure. One of the key characteristics of HIV pandemic is its extraordinary global genetic diversity. HIV1 main group or group M originated in Western Central Africa approximately 100 years ago. It has since diversified into a large number of variants, including 9 subtypes, multiple subtypes, and multiple circulating recombinant forms, or CRF, and thousands of unique recombination forms. HIV mutants are continuously introduced into new populations by mobilities and migration of humans. As HIV-1 variants intermix in different parts of the world, it is likelihood of generating the recombinant virus. Global and regional HIV diversity is complex, evolving, and is a major challenge to vaccine development, but not for the treatment. Between 2010 and 2015, HIV subtype C is the major HIV subtype that predominates in the patient. HIV subtype C accounts for approximately 50% of total infections. HIV subtype B was responsible for 12%. Subtype A was responsible for 10%. Change in the global distribution were seen over time, as in the right graph. The proportion of subtype A, D, and G decreased throughout 1990 to 2015. CRF01AE and other CRF form has consistently increased proportions in 1990 and 2015, contributing to a consistent increase in the proportion of all CRF over time periods. In the modern ART era, we have plenty choice of ART regimens and agents to decide a potent regimen for the patients. We can see a very high percentage of response among the clinical study. Most of the study participants respond well to the ART regimen. The percentage is greater than 80 or 90%. However, most of participants in these clinical trials are from Western countries, and most of them has subtype B virus. When we look specifically in some studies that show the response in other subtypes, the response among subtypes are the same, indicating that all of the subtypes have same response to ART regimens. So there is no compelling evidence that HIV subtype needs to be considered in the choice of ART regimen for first-line therapy. But what happens when the patient fails ART regimens? The response for ART is the same across all subtypes, but when the patient fails the regimen, resistant pathway may be different in different subtypes of HIV-1. For example, this is the slide show that there are two pathways of resistance mutations in patients who fail ACT or D4T containing regimens. If patients have subtype B virus, it is more likely that the virus or resistant virus harbor TAM1 mutations. In the other ways, if the patient has subtype non-B, for example, CRF01AE, if the patient fails ACT or D4T containing regimen, the patient will likely to have the virus that have two TAM2 mutations. So this is the example of different resistance pathway mutation that may occur in different subtypes of HIV-1 when the patient fails ART regimen. The other example is K65R in subtype C. In subtype C, there are in vitro data suggest that subtype C is more likely to develop K65R than the other subtype. This is an in vitro study that they did multiple passage of cells, and they culture the cells and put the virus into the cells culture. In this in vitro experiments, has been shown that mutation is more likely to select during serial passage of subtype C than the other subtype. When you look at the slide on the left-hand side, it shows that nucleotide sequence at codon 64, 65, and 66 differ between subtype B and C. And subtype C virus contain homopolymeric stretch of adenine bases. This leads to reverse transcriptase pausing during the synthesis of double-strand DNA from single-strand DNA intermediate templates. This is a process that's very specific and dependent of reverse transcriptase enzyme. On the right-hand side, showing that DNA synthesis performed with subtype C has more produced more K65R than subtype B. So this is an in vitro experiment suggests that this is a virus property that virus subtype C creates K65R more than subtype B. In the clinical study, also have the same, they suggest the same things. In many earlier studies, suggest that they found that there are very high rates of K65R in patients failed TDF-based regimen in the first line, especially in those who infected with subtype C more than subtype B. However, in recent study in the UK, Ellen White looked at the patients who failed ART regimen, a total number of 8,000 patients from UK who received a standard tenofovir containing first-line ART regimen were followed for a median of 3 years. In unadjusted analysis, the rate of failure was approximately twofold higher among patients who infect with subtype C compared to those infected with subtype B virus. But after adjust for the other factors, for example, demographic and clinical factors, after adjusting these factors, they found that there were no difference between subtype C and subtype B and non-C, either in univariate analysis or multivariate analysis. So this observation implies that there is no intrinsic effect of viral subtype on efficacy of tenofovir containing regimen in developed countries. The other drug that's commonly used nowadays is integrase inhibitors. This is a study look at the patient who failed Dolutegravir-based regimen, and they compare the genetic pathway of subtype B, subtype F, and BF recombinants. In this study, they found that in patients who fail Dolutegravir-based regimen, they usually fail with the classical resistant pathway, for example, Q48H, G140S, E138A. So these mutations were more common or more prevalent than in subtype F. In the same study, they found that the patient who failed Dolutegravir regimen, and if they infected with subtype B, it is likely that they have high level resistance to Dolutegravir and has cross-resistance to Dolutegravir and cross-resistance to Bictegravir comparing to those infected with subtype F. So this is a different genetic pathway that may occur in different strains of HIV-1. In this study, they look at B and F strain. When we look at Dolutegravir, which is commonly used now, in vitro studies suggest that the genetic pathway of resistant mutations were different in subtype B, subtype AG, and subtype C. In vitro study, serial passage experiments shown that subtype B, when they fail the Dolutegravir in vitro, it is likely that the virus will develop R263K, and in subtype AG, the virus will develop R63K G118R. And in subtype C, it is likely that the virus will develop G118R. So this in vitro study show the different pathway of genetic resistant development of resistant mutation in each subtype. But when we look at the clinical data, DCG is very strong and potent antiretroviral agents. Dolutegravir has very high genetic barriers. From the study of dolutegravir in treatment-naive patients, they found that there was no emerging dolutegravir-resistant mutation in patients who failed this regimen in spring trial, single trial, and flamingo trial. So this is in the clinical study. However, after this drug has been used widely, there are some case reports that emerge, and some case reports that mention about failure of dolutegravir in initial therapy. They suggest that in the patient who failed dolutegravir in the first line treatment, the patient usually in advanced stage of the disease, they usually had low CD4, high HIV RNA viral load at the baseline, and some of them had non-B subtype. For example, in this case described in New England Journal of Medicine 2019, they found that a patient infected with subtype F, the patient failed DCG containing regimen. And the other paper in Open Forum of Infectious Disease, they described a patient who failed dolutegravir based first line treatment. And in these patients, the patient had HIV-1 subtype CRF14BG. So in the real life practice, DCG failure in treatment-naive patients is very rare, but possible. One of the risks of getting DCG failure in treatment-naive patients is non-subtype B virus. In summary, the diversity of HIV has given rise to multiple strain and recombinant strain. The majority of research into ART agent and drug resistance has been performed mostly in subtype B, yet non-subtype B strain are responsible for more than 90% of global infections. We need more data of non-subtype B. Response to ART in treatment-naive patients are the same in all subtypes. However, there is emerging evidence of subtype difference in the drug resistance relevant to antiretroviral strategies in different parts of the world. Thank you very much.
I'd like to thank the first speaker. Now, let me move on to the second speaker. Our next speaker is Professor David Beck. David is a professor of pharmacology at the University of Liverpool at the United Kingdom. David has published at least 500 publications. He has become a well-renowned specialist in the field of clinical pharmacology of HIV and hepatitis C, particularly in the area of pharmacokinetics, drug-drug interaction, and optimized things therapy. He's a past editor-in-chief of the British Journal of Clinical Pharmacology and currently a member of the editorial board of a number of journals. Back in 2015, he has received a lifetime award from European Clinical Society for his contribution to the field of HIV/AIDS. So please join me to welcome David Beck. So David, floor is yours. Thank you very much.
So thank you very much for the introduction. It's a great pleasure to be part of this exciting meeting. Here are my disclosures. I want to go through first, just very briefly, antiretroviral therapy. Where are we currently? Secondly, antiretroviral therapy and gender. PK differences, are they important? And then thirdly, antiretroviral therapy and gender drug interaction issues. I will only briefly be touching on ethnicity issues due to time constraints. So where are we as far as antiretroviral therapy is concerned? Looking back over the last 30 plus years, it's clearly an exciting direction that we've traveled with so many different individual drugs, drug regimens, and exciting developments. There have been pivotal times, of course, the mid-90s, 1996, the Vancouver HIV conference, and the New York Times headline, "We're talking now about life and not death," and that was the advent of the protease inhibitors. Latterly, we've become the integrase era, and these have been a group of drugs which have made a profound difference as far as patient care is concerned. We've had a number of strategies to reduce the burden of drug over the years, reducing the number of doses a day, reducing the number of pills, reducing the number of drugs, reducing the drug dosage, attempts to reduce the number of days on antiretroviral therapy, and then recently, of course, the increase in the dosing interval with the advent of long-acting therapy. I think it's worth just looking at the long-acting technologies that we have. Of course, the most developed are the long-acting injectables with cabotegravir, rilpivirine, but there's some exciting work with microneedle drug patches, subdermal implants, vaginal rings, oral nanomedicine, and infusions. So we really do have a portfolio which going forward is presenting us with exciting possibilities. So antiretroviral therapy and gender, PK differences. What do we know and what do we need to know? They are two key questions. Well, we know that 18.8 million women and girls are living with HIV. And if you put this into the perspective of global demographics, then 52% of people living with HIV are female, 48% are male. And this chart also gives a breakdown by different ethnicity, with the predominant being Black. Recently, a really highly provocative and relevant paper was published just a couple of months ago on phase 3 trials of new antiretrovirals being not representative of the global HIV epidemic. And this looked at Dolutegravir trials, Bictegravir trials, and TAF trials. And I think it's worth just noting that within Dolutegravir trials, 24% are female, in Bictegravir trials, 30% are female, and in TAF trials, 27% are female. And you can look also at the perspective of different ethnicities within this chart. Taking just some examples of individual drugs, what is the gender effect on the pharmacokinetics of Dolutegravir? And this is a population pharmacokinetic analysis of treatment-naive patients, 563 patients, of which just over 80 were female. And these were analysis looking at plasma concentrations and then doing both univariate and multivariate analysis. Females, shown at the top, had higher concentrations than males, around 27% higher. But I want you to note also the relationship with weight. So lower body weight individuals had higher exposure, higher body weight individuals had lower exposure. So there is a link between higher exposure and weight. The bottom line of this study was that the author said no Dolutegravir dose adjustment was necessary by these particular intrinsic factors. I think we can go further. And in other studies, you can say that no dose adjustment of Dolutegravir for women would include women on contraceptives and during the second and third trimester of pregnancy. But there's also just a caveat around the relationship of drug concentrations with effect, and in this case, adverse effect. Because there was a study from Germany showing higher rates of neuropsychiatric adverse events leading to Dolutegravir discontinuation in women and in older patients. Now, it has to be asked, is this PK related, that the increase in side effects were related to concentration? But also, I think we need to note importantly that the rates in this particular study were much higher than rates in the pivotal trials that we have for Dolutegravir. What about darunavir cobicistat, a protease inhibitor? Well, in this particular study, which is just published ahead of print, there was a total of 127 people living with HIV, 42 females, around 400 serum concentrations analyzed, and gender was found to be a significant covariate for clearance, a 21% decrease in clearance in females in a univariate model, but body weight was not taken into consideration. Then what about TAF? These are data from a study presented at HIV Glasgow in 2018, showing that the TAF exposure, the area under the curve, was higher in females, 47 females out of 530, and this was a 15% increase, a 12% increase in females for the Cmax parameter. Now, there's also been a meta-analysis of many studies, not only in HIV, but beyond HIV, comparing gender pharmacokinetics. This from colleagues in Basel, Switzerland. And looking overall in this meta-analysis, there was a 20% increase in females of Cmax, a 17% increase in area under the curve with a decrease of clearance of 11%, explained by differences in body weight and also metabolism with reduced first-pass hepatic metabolism. But it's really important to know that even these changes which have been documented are within the bioequivalence, the 80-125 range, which we would normally accept. What about the long-acting? Well, there's some interesting data on gender effects with long-acting cabotegravir and rilpivirine. I want you to note these are data from the Atlas and Flare pivotal phase 3 trials of the long-acting injectable, monthly injection with an oral lead-in of cabotegravir rilpivirine. And looking at cabotegravir exposure, the orange is the female, the blue is the male. There's a decrease of 40% in exposure initially, but latterly, after several injections, there is an increase in exposure in the females. Now, there's a trend to seeing this with rilpivirine as well, but the changes are moderate or very, very moderate in comparison with what we're seeing with cabotegravir. It's also worth then looking at the HPTN 077 trial for long-acting cabotegravir for PrEP, because here we see a similar type of profile. And this is injections which are initially 4 weeks and then 8 weeks. The red color is the females, the blue color is the males. This is plasma exposure. And you can see that the plasma exposure initially in females is lower than it is in males. But then, then latterly, it becomes, after several injections, the concentration is higher, the red color in females than in males. So after the second injection, the C trough is 1.82 in females, 1.29 in males, significantly different. After the third injection, 2 versus 1, highly significant. So there clearly are some differences in exposure. We can look at this also in terms of after the last injection, how long does cabotegravir remain in the bloodstream? And this is an important analysis from HPTN. It's the cabotegravir tail. And the blue color are male participants, the red color are female participants. And after that last injection, you can see the drug concentrations persisting, and this is time in weeks. And you can measure concentrations above the protein adjusted IC90 for 1 year, even out to, in some patients, 2 years. But in the female participants, this is even longer. The slope is different. And so there are individuals with drug concentrations out 2 and 3 years. So there's a difference between males and females in the tail. And the authors discuss this in the paper and said our observations that detectable or quantifiable concentrations of cabotegravir may persist for years, females greater than males, after the final injection, has implications for the risk of HIV, for drug-drug interactions and resistance after dosing cessation. This gives us a segue into talking then about drug interactions. Antiretroviral therapy and gender. What about drug interactions? The first point to note is that polypharmacy in men and women may be different. This was illustrated in a study from Madrid in Spain, looking at drug interactions in people with HIV, a population-based study looking at prescriptions. The prevalence of polypharmacy, defined as greater than 5 non-antiretroviral drugs, was clearly higher in HIV-positive females than in males, significantly different, and also in HIV-negative females versus males. And a discussion about why polypharmacy may be higher in women is that women may consult their healthcare professional more frequently and therefore detect comorbidities and will receive medications more than in males. However, just a caveat, another study in older women, so in an older population of women and men, in the JEPO Italian cohort, did not show a difference in polypharmacy. The bottom line, it was the same in males and females, but it did highlight some differences in comorbidities. That, for example, in males, cardiovascular disease was higher than in females, whereas in females, bone disease was higher than in males. So we need to be aware of differences in comorbidities as well as potentially polypharmacy. In the Liverpool Drug Interaction Database, which many of you will be familiar with, we can analyze which particular co-medications are being searched for. This is an analysis from January to August 2020, 3.5 million searches globally. The top search drug over this time was atorvastatin, 45,000 searches, followed by omeprazole, metformin, amlodipine, paracetamol, rifampicin, for example. And so here we can see the global searches. Now, I would suggest there may be just one drug here or one, in this case, calcium supplement that potentially is higher in women than in men. There may be others, but we don't actually analyze the data male and female. And we can look at data from Malaysia. We can do countrywide analysis of the data. This is Malaysian data relevant to APAC. And you can see here calcium supplements are much higher up in the list than in the overall global search. So this is a way of looking at what may be different between men and women. I think if you had to analyze what co-medications are frequently used in women, then oral injectable contraceptives, hormone replacement therapy, supplements, as we've just briefly discussed, herbal remedies, antidepressants, bisphosphonates, and tamoxifen would be on the list. So what about long-acting contraceptives? Well, I think it's really important to note that there are potentially important drug interactions with long-acting contraceptives. And here we have data from a study of the contraceptive implant containing levonorgestrel in individuals receiving efavirenz-based antiretroviral therapy. And here the exposure of the levonorgestrel over a year was around 50% if the individuals were on efavirenz. And in this particular case, there were 3 unintended pregnancies in the efavirenz group. Can that be overcome by doubling the dose of the levonorgestrel implant? And that was a particular presentation at a recent CROI. And the answer is that it wasn't fully overcome by doubling the implant. So it does remain particularly important for us to have a strategy for overcoming these sort of interactions. What about hormone replacement therapy? Well, I'd like to draw your attention to the Liverpool database where there are prescribing resources. And here we have a hormone replacement therapy treatment selector looking at the different hormone replacement therapies with antiretrovirals. Green being no interaction, the orange color being a potential interaction requiring a dose modification. And it just summarizes the data with the more risky drugs being the boosted protease inhibitors, boosted integrase, and the induction of efavirenz, etravirine, nevirapine. I think the last point we need to make is around the issues of drug interaction concerns in transgender individuals. There was a news release from NIH a couple of years ago. Drug interaction concerns may negatively affect HIV treatment adherence among transgender women. So there is a concern about adherence to medication in transgender individuals receiving hormone-affirming therapy. And this has been the subject also of a very recent review, which is online from July. We also have some prescribing resources for gender-affirming treatments. These are in the Liverpool database. These are estrogen and anti-androgen preparation. Looking at the HIV drug as the perpetrator of an interaction, there are many greens, so many drugs have no interaction. But again, looking at the boosters and efavirenz, for example, there are interactions that we need to be aware of, particularly with estrogen preparations, and ethinyl estradiol is contraindicated. So the other aspect of this is to look at the HIV drug as a victim. And I would just point your attention to 3 cohort studies looking at decreased tenofovir diphosphate concentration in transgender females. And here looking at the tenofovir diphosphate ratio to DATP, which was lower in transgender individuals. So these 3 cohort studies, one from Thailand shown here as well, provide evidence that feminizing hormone therapy may alter PrEP, TDF-FTC pharmacology, pointing to a reduced efficacy or stricter adherence requirements. So I think there are some key messages. Firstly, there's evidence of PK differences between men and women for orally administered antiretrovirals, high drug exposure. But body weight is likely a key driver with this, along with reduced first-pass metabolism. I think it's difficult to pinpoint any real clinical relevance of gender per se on oral PK. But there is evidence of PK differences between men and women for the long-acting cabotegravir and rilpivirine, with the higher drug exposure in women after multiple doses and the longer tail. And I think this does have potential relevance for managing the PK tail. And then finally, there's evidence that polypharmacy is more common in women, with problematic co-medications that need monitoring with some antiretrovirals. And note the important area of drug interactions with gender-affirming therapies, potentially reducing the efficacy of PrEP. And ethnicity? Well, I'm sorry, that needs another discussion in the future. So my grateful thanks for a wonderful Liverpool team who helped with the Liverpool websites. And I'd like to thank you very much.
Thank you very much, David, for your very nice presentation. For the discussion and questions, so we will have a roundtable discussion later on. So let me introduce our last speaker of this session, Mark Nelson. So Mark is a consultant physician at the Chelsea Westminster Hospital, London. He also a professor of medicine at the Imperial College Medical School. He has built a large HIV practice focusing on HIV patient care, co-infection with hepatitis B and C, and also the clinical utility of new antiretroviral agents. He has published over 500 papers in the field of HIV and hepatitis. He actually had chaired the British HIV Association guidelines for the Committee for the Opportunist Infection and for Hepatitis C. And he also the member of the guideline for HIV treatment and care as well. So his talk will cover, actually going to share his experience mainly on the clinical case presentation. So please join me welcoming Mark. Thank you very much, Mark.
Thank you very much for inviting me today. I'm in London. I wish I was in Bangkok, but such is the way of the world. I'm going to present to you really a very simple case. This is a 56-year-old, low CD4 count, good ongoing viral replication. Would you treat or not treat? And I think the answer from all of us is going to be, we're going to treat. The question is much more, what are we going to treat with? And of course, we have a wide choice of drugs nowadays, multiple drugs in multiple classes for both us and the patient to choose from. And it's very important to realize that, you know, one size doesn't fit all. I think we've become almost normalized to giving our favorite drugs to our patients and not perhaps taking into account various different points which matter to the patient and ultimately to us when we come and choose therapeutic options. We do need to think about what we're trying to achieve with these drugs. And of course, we can look at that in various different ways. We can look at undetectable viral load, normalization of the CD4 count, reduced, preferably nil transmission, and good quantity and quality of life. And the fact is, with the majority of the therapies that we have at our fingertips, we're going to be able to achieve those. But we need to think about how we choose individual therapies for individual patients. And of course, there are various factors which come into account. Firstly, related to the drugs, data on efficacy, toxicity, the ability to adhere to in the long term, potential drug-drug interactions, barrier to resistance, and we can't get away from the issue of cost. Then there are disease factors such as how high is the viral load, how low is the CD4 count, and do they influence the drugs that we choose? What resistance mutations are present, the tropism of the virus. And what we're going to talk about today is the influence of clade. And then perhaps most importantly, patient factors. Who is that individual in front of you? What comorbidities, what co-infections do they have? What other medications are they taking or they may take in the near future? Their HLA status as well as other genomics, what the patient wants from their therapy. And again, we're going to discuss the issue of sex, being male or female, and does that influence our choice of therapy? So let's start off with clade. You'll be aware that HIV probably started in Kinshasa and then has as one virus and then has spread and developed into various different clades, clade B being predominant in Europe and the Americas, clade C being predominant in sub-Saharan Africa. Does that clade really matter when we come and choose therapy? Well, let's see. Let's add into the mix in this patient who remains 56, low CD4 count, viral load of almost 100,000. But does it matter that they're subtype C? And I think when we talk about clade, we need to think about success and failure. So what is the influence of clade on our ability to gain virological success? And what is the issue if we fail? And how does clade influence failure and what resistance mutations may develop? Now, I think the fact is that we're all aware that with the drugs that we have, we should be aiming for near 100% virological success. And I think there is very little data, if any, to suggest with the current drugs that we have that clade is going to have an influence at all on our ability to succeed. The one most modern bit of data which suggested that there may be an issue was the Atlas and Flare data looking at Dolutegravir and Rilpivirine and the issue of clade A. And really, is it an issue of clade A? Or is it other things? Is it to do with the viral load? Is it to do with mutations that were present in these patients? Is it to do with their geographical site? And I think none of us can take away from this study a firm conclusion that clade is going to matter, although of course we must look out in the future for any signal suggestive that indeed this is the case. So I think as regards success, we really shouldn't be influenced by clade. However, if we're talking about failure, then I think clade may well matter. So we know that clade may influence various issues in the viral replicative cycle. Clade may influence entry with differences in GP120, GP41, polymorphisms. It may affect your reverse transcriptase, again, with different codon usage, RtRNA template, and again, polymorphisms, and similar when we look at integration and maturation. So because of these differences between viruses, when we actually fail, we may actually develop different mutations. Now, I think a lot of the data to suggest this matters comes from many years ago when we were seeing not an inconsiderable amount of failure due to the difficulties in taking the drugs and indeed the inherent efficacy of the drugs. And nowadays, again, I think we should really question whether clade really does matter when we see so little failures. Certainly, if we look at clade C, as in this person, but as regards differences, as regards polymorphisms and associated drug resistance, we can see that K65R may be preferentially selected in clade C. Other nucleoside resistance mutations similarly. And again, when we come and look at NNRTIs, again, we see different frequency of mutations developing to different drugs in the case of virological failure. Now, some of this is driven by laboratory data rather than true in vivo data, but it's something to think about potentially if we are worried about failure in this person. This again is quite old data, but it looks at clade C and the fact that when we used to use the non-nucleosides efavirenz and nevirapine, we got a novel mutation with clade C at position 106 with a change from V to M. Why was this happening? Well, if we look at the makeup of the valine, you'll be aware that each amino acid is made up by 3 bases, but different bases can give rise to the same amino acid. And you can see the bases in subtype B and subtype C differed. And of course, the virus is going to go down the easiest route. And the single mutation change in clade B would change your V to A. But in clade C, you can see a different single mutation, V to M. And indeed, if you think about subtype B, to get to the M, you'd have to have 2 codon changes. And similarly with subtype C and the develop of the V106A. So you can see that here, clade does matter as regards what mutations are developed. And of course, the differing mutations may lead to different choices that we have to actually rescue this patient in the future. Similarly, there's data on K65R leading to being increased in subtype C and certainly in the test tube developing more rapidly. And if we look at some of our less successful drugs, if we look at nelfinavir, which used to be widely used as a protease inhibitor, but was not as efficient as the drugs that we have nowadays, again, you can see a different mutation being selected dependent on your clade, and this led to different ability to actually rescue these patients with newer protease inhibitors. And again, if we look at other protease inhibitors, clade influences the mutations which develop. So I think the only reason that clade may influence our choice of treatment in this patient is if we had concerns over non-adherence, concerns over resistance development in the future. But I think much more importantly than worrying about the clade would really be to address those issues up front and make sure they didn't influence the success of our treatment regimen. What about sex? Well, when we're talking about sex, we're talking about females and male. I've made the patient now a female, 56-year-old, CD4 count 127, viral load 100,000, subtype C, as we said, but now we're putting into the mix that she's female. So does sex matter? Does it really matter if it's a male or a female? Well, this is an old English expression when you ask what are little girls made of. They're made out of sugar and spice and all things nice. And there are differences in women as regards body composition, female specific organs, their immune response, and the potential to use surrogate markers. Similarly with men, they're made out of snips and snails and puppy dog tails. And again, there are differences. There will be differences in men compared with women as regards their body composition, immune responses and surrogate markers, and of course they have different male specific organs. If we come down much more to a molecular level and a body level, then we again see changes. Clearly, women are likely to have different weights. They tend to be of less weight. They may have more fat and therefore different fat distribution. And at the molecular level, we see sex variation in cytochromes and expression of P-glycoprotein, which is an important transporter, as you're aware, is often lower in females when compared with males. So that beggars the question, really, do we need specific studies for females? And indeed, you can turn that on its head and say, do we need specific studies for males as well? And there's been a lot of work done and a lot of comment being made about females and that they are underrepresented in clinical trials. That not always the case in other areas. This is an expression of data looking at clinical trials in cardiovascular disease, and you can see that the number of patients in the studies was relatively equal. So it is quite possible to get a almost 50-50 distribution. And of course, we're aware, at least in Western Europe and the Americas, that there may be less females available compared with males because of the lower incidence and prevalence of HIV infection. And compared with cardiovascular disease, of course, that may matter. But I think that isn't the answer to what's happening. I think it should be possible to get more females into clinical studies to answer this important question. You know, typically the proportion of women in clinical trials has been less than 20%, and we do have sub-analyses, but because of the low numbers, they're often underpowered. Now, I think the important thing that comes out over and over again from these studies is that there isn't a difference in efficacy, but there may well be differences in toxicity. And of course, it's really important to think about pregnancy, but it's not the only consideration as regards differences in gender. How are we doing as regards clinical trials? Well, pretty miserably, really. If you look at the most modern trials, we're still under 20% in the majority of studies recruiting women, and the same as switch studies, approximately the same. And so again, I think we have to ask the question, what are the barriers to this enrollment? Why are we not seeing the same number of women as men, or more women being recruited? As we've talked about, it may be that there are lower numbers, but in many areas of the world, you know, females with HIV are equal or outnumber men with HIV. Multiple methods of contraception, but this is no different in any other study looking at a similar age group where we do see higher rates of females. The uncertain pregnancy intentions, that sounds very masculine to me, rather than someone being able to say, this is what I'm planning to do. And of course, there are other reasons. It may be difficult to attend because of other issues in people's lives, childcare, etc. There may be a feeling that women don't need to go into clinical trials. They may not be offered because of these reasons. And I think there's also the issue of trust. And unless we start to recruit females and give them the answers that they deserve, there is this question of whether there is trust between the recruiter and the individual. As we've said, viral efficacy, though, is similar, but we may see differences in toxicity, and it's been shown with several drugs in drug studies that there are different rates. And many of these actually, I will take that back, don't come out from within studies, but are looked at in larger cohorts later, which shows what we may well be missing by not recruiting equal or similar numbers of each sex to the clinical trials. If we go back and look at nevirapine, I think in the nevirapine data as regards to the serious toxicities of skin rash and hepatotoxicity, we had different cutoffs for risk for females and males. So if you had done a study or a cohort study only in males, you would have had a very different answer than what we saw for females, and put the females at increased risk of this toxicity. So let's take this lady. She's worried about toxicity. She's particularly heard about the new issue of weight gain with some of the antiretrovirals. She's post-menopause, and the treatment that she's been receiving has revolutionized her life. You all will have seen the advanced data and the suggestion that there is an increase of weight, possibly with integrase inhibitors, which is made worse by using TAF rather than tenofovir. But if we leave that to be discussed elsewhere, what we do see is that this is an issue greater for females compared with males. And I know that I've just seen a lady in clinic this morning who refused to go on TAF based on the fact that it may increase her fat. Even though I felt everything else being equal, that remained the best choice for her. So it does matter to people, and this kind of data is important. She's taking hormone replacement therapy. And again, we need to be aware that other treatments that people may be taking, not just females, but everyone, may influence our choice of treatment. And the use of drugs which have a low influence as regards drug-drug interactions, principally integrase inhibitors, is going to be important. But we also see with doravirine a lack of drug-drug interactions with hormone replacement therapy. So this lady actually chose to take, having been given various choices, tenofovir, lamivudine, doravirine, which all comes in this country in a single tablet. So she could be given one tablet once a day. And I would expect that to deal with her virus, for her viral load to go undetectable and her CD4 count to rise. However, we need to be aware that having made that choice based on her sex, possibly her clade, I don't really think it's the clade, it's really on her sex and her worries about weight gain and drug-drug interaction, is we have to start asking questions. Is this really the best thing for her? You know, we're actually here to treat HIV infection. We have no data to suggest that doravirine is as good as an integrase inhibitor. We have no data to suggest that it isn't. But, you know, we are missing that experimental data to say, what in a clinical trial does doravirine offer as regards an integrase inhibitor? As a female, are we worried about her getting tenofovir and implications in the future for her bone and renal health? Are there other DDIs with the doravirine which she may be taking other medications or be due to take other medications in the near future? Whenever we use a new agent, we have to be aware that there may be new toxicities. You know, many of my patients will come in when offered new drugs and say, well, actually, if it's not broke, don't fix it. If I'm happy, even though it's an older drug, I'm happy on it, it's not causing a toxicity, let's leave it all alone. And again, in this lady, we haven't talked about her adherence, but could clade affect her resistance to, if she fails, this being a non-nucleoside doravirine, which we know had been influenced by clade in the future? I think in conclusion, does clade matter? Probably not. Does sex matter to us all? Yes.
Thank you very much. All the speakers, Opass, David, and Mark. I think it's clearly all the presentation and also the case discussion will set up, you know, to have this roundtable discussion in terms of the subtype, gender, ethnicity, do they impact our HIV care? So please be reminded that at 15:44 we have another session, session 4. Now let me start by while we're waiting for questions. So let me start by asking the issue that we have heard from the talk that HIV subtype probably related to the risk of HIV drug resistance and maybe lead to biological failure. So do we really need to do subtyping, and when we should do it?
Okay, I think this is my questions. So I think that for the response to the treatments for treatment-naive patients, there has been no evidence to show that there are suboptimal response in the patient with different subtype for treatment-naive patients. So I think that when you start the treatment, response are the same. And however, when the patient failed the treatment, some of the genetics background, the difference by subtype may drive some specific pathway of resistance that may produce some specific mutation that confer resistance to some drugs. For example, in subtype CRF01AE in Thailand, when patients fail stavudine, some of them have K65R. This is the example of the subtype difference and the drug resistant pattern that may
you may see in some subtype. However, for the reason, I think that of this subtype respond in the same way, because most of the trial there has been no evidence show that subtype difference if the different respond in terms of the treatment naive patients.
Mark, do you have any?
I totally agree. I mean, the problem with clade is you can't change the clade. You know, you're not going to change someone's clade. So, and I think we can start drilling down into minutiae. I think what we need to concentrate on much more is why are patients still failing, rather than the worry over a small number of people failing with a clade which is going to lead to a different resistance. I think we have a lot of work still to do looking at why people still fail, and I think that isn't because of clade, and making sure that people get the best available drugs. And I think sometimes we can start looking at minutiae, and letting that influence our choice of treatments would be frankly ridiculous. We have fantastic drugs which are going to work in the majority of people, and we need to ensure they don't fail.
So, Mark, in your case study, that a lady with clade C. So my question is, let's say if because it practically we won't know at the baseline that this lady carrying the clade C or not. So if we, in general, if such a lady that concerning about weight gain, you know, and have CD4 less than 200, beside Dolutegravir, watch out should be, and also a concern of the
but I think we then, I totally agree, and of course case Cs are there to be exaggerated and to try and make points rather than to go back to the reality. And I think, you know, that different people will have worries over different possible toxicities. But again, we're still unclear at the present time exactly what's going on with these drugs, both with integrase inhibitors and with TAF. And until we do, we can't let that influence. And I made it quite clear, you know, we gave this lady Dolutegravir, but is that really the best choice for her as regards getting virological success when we're lacking data of this drug against integrase inhibitors? So again, I wouldn't take too much from the case that you shouldn't use integrase inhibitors or you shouldn't use TAF. It's really those questions at the end. Do we let things which are unclear influence our choices too much rather than giving the best available treatment which we have for that individual?
Okay. Yeah.
And the reason I gave it, I'm sorry to take the time, but the reason I did it is nowadays is suddenly with TAF, every patient is being told you may put on weight. And I think that's wrong when we know that TAF is a very efficacious drug, a very safe drug. Whether you actually need it, it's a different argument, 3 drugs versus 2 drugs, etc. But it's you're putting people off a highly effective drug by saying, you may put on weight, and people don't want to put on weight.
Yeah. In terms of the weight gain, do we have any evidence right now that because the weight that gaining is mainly from the fat, you know, increasing up to 70%. So is there any concern of the visceral fat deposition in this group of people, or liver, you know, fatty liver? Or
well, I think yes. I think if you're putting on fat, you're putting on weight. I think things like fatty liver, but people put on fat. You know, as you get older, you put on fat. It's a natural thing. So the question of this is how much of it is a return to the norm, how much of it is abnormal. Clearly, I think it's something that we need to monitor. Clearly, it's something that we need to do research on. But you know, I don't think we need to get overtly worried in the majority of people. Certainly in our clinic, you know, yes, we see the occasional person who puts on a large amount of weight, both with integrase inhibitors and with TAF, but the majority don't. You know, so and we need to be, as I say, I'm sorry, sounding like a stuck record, but we need to ensure we give the best drugs available to us to treat HIV and deal with any issue that develops at a later time.
Sure. Yeah, that's a very good point. I think a very strong point. I think one of the questions I'd like to ask to maybe all of us here, that based on the 3 cases that Opass has presented, even on taking 3 drug regimen containing Dolutegravir and develop a very rapid drug resistance and virological failure. So what are the most likely cause of these 3 cases, and what we can learn from these 3 cases? Mark? Yeah.
Who do you want to answer?
Yeah. No, the question is what we can learn from the 3 cases that failing the 3 drugs DTG containing regimen. Is really because of the very low CD4 cell count, or high viral load, because 2 of them has viral load more than a billion.
I don't think you can learn anything from 3 cases. I think it shows the danger of us chanting mantras that, resistance is impossible. Clearly, what we know is that it's very difficult to develop resistance to the 2nd generation integrase inhibitors, but it can happen. And I suppose, again, the lesson I would learn from it, if we look at these cases, they were patients who were sick with HIV, with low CD4 counts and high viral loads. And I think the message is get these people tested earlier. We don't see that. We haven't seen the resistance in other groups. It may just be a stochastic event which happens, probably is linked to the higher viral load, the greater replicative rate. And I think the message isn't that, we're going to get a whole load of 2nd generation integrase resistance. It's don't let individuals get in such a state.
Okay.
Yeah, I agree with Mark. I think it's really important. And if you look at the papers, the 3 individual papers, and you go through it, clearly you have to look at multifactorial aspects of the high viral load, the low CD4, and whether or not there was adherence issues, whether or not the drug concentrations were adequate from a pharmacological perspective, and whether other potential confounders. So I think it's multifactorial, and it's very hard to learn from just looking at 3 cases, but we do have to, and I think the history of HIV is that we can learn from cases, but we have to be very careful how we interpret them. Okay,
good. Now, David, because you didn't have the time to cover pharmacogenetics and ethnicity related to drug exposure and toxicity, could you address this a bit?
Yeah, so I think we go through phases in HIV, and a number of years ago, Mark and I were involved in various studies around pharmacogenetics, and there was certainly a movement. Could we genotype all patients before they went on treatment with different genes, particularly around the efavirenz era? But interestingly, last week at Glasgow conference, efavirenz genotyping came up again in relation to weight gain, because in the advanced study, which of course, people can say, well, the advanced study stands out on its own in terms of weight gain, but there was evidence from the advanced study with efavirenz that the slow metabolizing genotype, if you were a slow metabolizer of efavirenz, then it seemed to have a protective effect against weight gain, or you had less weight gain if you had higher efavirenz exposure. Now, you can go into potentially what reason could there be. Is it that people are feeling less well if they've got a lot of efavirenz, because efavirenz has been linked to having maybe more CNS effects or maybe nausea? So what is the reason for that? Are we going to do anything about it? I think it's very unlikely that people have said, oh, let's genotype patients with CYP2B6 if you give them efavirenz. Well, of course, efavirenz is moving off the agenda anyway. And there have been other genotypes that we've talked about, even for Dolutegravir. Could neuropsychiatric effects that have been put forward for Dolutegravir be linked to a UGT1A1, which is the genotype which is relating to Dolutegravir metabolism? Again, they tend to be pretty small in terms of their effect. So it's an interesting discussion point. You know, we could discuss it for a long time, but whether we're ever going to see any sort of long-term clinical utility, I don't think so.
Okay. Yeah. In terms of the long-acting injectable cabotegravir and rilpivirine, you have shown the data that in female seem to be have longer tail of the pharmacologic tail. Do you think that in terms of the plan to cover the tail, if anyone want to stop injection, is there any different so far? So what the practically how long we should cover by oral ART to cover the tail in people want to stop injection?
Well, I think we're learning all the time about that, Kiat. It's the best data has come from HPTN 077, which is the PrEP study with cabotegravir. And clearly there is a difference in the length of the tail. But what we have to recognize with long acting is, and I don't want to go into too much detail, but it's called flip-flop kinetics, in the sense that the tail is not governed by the elimination of the drug, the clearance of the drug. It's driven by the absorption of the drug from the absorption site. So clearly there's a difference in men and women in terms of body mass, fat and muscle, etc., which is governing the absorption, which then governs the tail. Now, in terms of practical, that tail can be from anything from 6 months to 2 or 3 years. So we do have to look at strategies to cover the tail. And I'm not sure that we've got there yet with the best strategies, but we're going to have to give patients some oral cover with that tail in order to prevent resistance. Because there was one patient in a rilpivirine trial, which Mark at Chelsea and Westminster, and Mark probably knows the details better than I do, from an original rilpivirine PrEP study where there was infection during the tail of rilpivirine. So we do have to cover the tail. I don't know whether Mark's, in terms of practical, the way forward for covering the tail. I mean, Mark,
I've been thinking, David, it's going to be very difficult, isn't it? If you've got a tail which may go out to 2 or 3 years, and how do you decide how long to cover the tail for, especially in someone where it's being used as PrEP, who's clearly saying, I don't want to take PrEP anymore. And then, you're saying, we've got to take PrEP. So one of the questions I was going to ask you, because of all, it's linked to this in some ways, but when we talk about females and different pharmacokinetics, we talk about drug-drug interactions. Do you think the time has come to go back and be thinking about TDM again? I mean, what we're really talking about is the individual, isn't it? So not all females have the same pharmacokinetics as the same way all males do. It's about all individuals. And has the time come to look at TDM again and its role, particularly in identifying toxic and dealing with toxicities? And in this kind of patient, will we need to do drug levels to see exactly where we are and when is it safe to stop?
No, and I think that's a really good question. And that discussion, I think, in terms of the tail and how to manage the tail for long acting is one that certainly needs to be resurrected. We go through cycles with many aspects of HIV care. And again, TDM was something that we used to do with, and I know colleagues in Thailand, Indinavir and the older protease inhibitors, and then things went out of favor. But there are questions, and if we're going to individualize therapy effectively, then TDM may be part of the jigsaw. The real issue with TDM is getting the results back quickly and having labs on site. So what we really need is very simple tests, just like we need for COVID, simple immediate tests. For TDM, for HIV drug levels, we're going to need simple one-day turnaround tests in order to help us manage that. Otherwise, you wait 2 weeks or 3 weeks for the results, then I think it's very difficult.
Okay. I don't think I have any topic to bring up. Any of us, do you have any point you want to, raise or emphasize to our audience, please, in terms of how to implement what we know right now and the best practice working on?
So I would say I think the important thing is to treat for success and give the most successful treatment, and to deal with toxicity very, very actively. I think there is no need, wherever you are in the world at the present time, for someone not to have an option to switch to something else. And I think there is nothing wrong with switching around to deal with toxicity. And we know that the biggest problem isn't clade, I think, isn't sex. I think it's toxicity and fear of toxicity which drives the virological failures. I think really, we have very successful treatments, and I think it's all about dealing with the toxicity. And that's why I was asking David about, whether TDM really had a role. It's, I think when we first started using therapeutic drug monitoring, it was about getting the right dose for success. It's really now about dealing with all the toxicities and the fear of toxicities and being able to individualize treatment.
Yeah, Mark, may follow up on that. In the era of very potent and very friendly integrate inhibitor regimen, do you think that in your practice in the past few years, that could you share with us that in UK, so what the majority of people taking the regimen right now? Because in our region is only the high income country that entering the single tablet integrase inhibitor, but majority just in the transition from efavirenz to DTG.
Sure. I mean, I think that the first choice of treatment here is going to always be an integrase inhibitor at the present time. And I think that, as I said, I think cost still is a factor. And so cost will influence which integrase inhibitor we're able to give to our patients. All right, so I think that's it. But I think we do need to look at what we're doing, looking at the data, looking at two drugs, the possible advantages of two drugs, the possible disadvantages of two drugs. We need to look at the data between integrase inhibitors, and we need to look at where the data is missing. But I think, what we're left with now is it's an integrase inhibitor, and it's what you add to that integrase inhibitor. I think that's the big question that we still don't know.
Mm-hmm. In terms of the backbone in the UK, so using mainly TAF right now, or still?
No, as I said, it's driven by costs. So clearly, generic Truvada is cheaper than TAF, so we can use TAF where we need to, but we're still left with our buyers or our payers actually influencing antiretrovirals and say, give Truvada if you're going to do it, which therefore then really drives some clinicians to then say, well, I'm not going to give tenofovir, or I'm not going to give abacavir because of the potential toxicity, and they are looking at two drug regimens. And clearly that's not just a ViiV thing. Clearly MSD are looking with their new drugs, looking at two drugs, so that's what I mean. I think the question is, what do you add to your integrase inhibitor rather than what is your backbone? It's what you need to add to it for success. And what you are happiest with, and what your patient is happiest with.
So Kiat, what's the discussion in your region around 2 drugs versus 3 drugs? I mean, is it a big topic, or is it something which is not on?
Yeah, in the next session, I'm going to present the 3 versus 2 drug. Yeah, I think for the 2 drugs in our guideline is not considered as a first line yet, because as you know that if you go with DTG3TC, which is the concern will be you need to screen the baseline hepatitis. You have to make sure that you to look at the viral loads is not too high and the CD4 is not too low. So I think that limitation, but there's a trend of considering these dual drugs regimen as maintenance therapy, particularly for those who have kidney problem with TDF. So when they're taking, a triple regimen type regimen, and they start to have a kidney issue, so we would drop TDF and go with DTG 30C, or even DTG with Ripuronine. Yeah, that's an option. But it's not the first line yet. Is that commonly used in start to be a first line regimen in UK? I saw the guideline in Europe that recommend as one of the preferred options.
I think it's always an option. It's always an option.
Okay,
David,
all right.
David, can I ask you about females and males? Because we have this discussion constantly within the context of HIV. Why don't we have the discussion outside? So in hepatitis B, hepatitis C, we don't have this discussion. Do we have it in? Why are we having it just in HIV, do you think?
Yeah, I mean, I think there's a political...
Or perhaps it is being done elsewhere, I don't know, but...
No, I mean, I think there's... The discussion is certainly greater in HIV, and I think there's a number of sociological, political reasons for that. But I come back and I tried in my talk to sort of give some indication that the major driver to me is more body weight than gender.
Sure.
I mean, I think there are gender effects, but body weight is the bigger driver. And we can see that in most studies. And overall, on a meta-analysis of more than 70 or so drugs from HIV and other therapeutic areas, the kind of difference is around 20% difference in exposure between men and women. So women have 20% higher. But, as I say, a lot of that's driven by body weight. So I don't rule out that there are metabolic factors, that estrogens and progesterone, that can drive those metabolic differences. But it's very hard to point out when normally for bioequivalence in any study, you're looking at a 120-80 or 125-80 sort of range. So you're not really going outside the bioequivalence range unless you go to extremes of body weight.
Yeah. I think in terms of the body weight driven, I think in our previous study that we have been involved in the Ripuronine phase 3 trial, when they did the post hoc analysis comparing the Thai and the Caucasian and Black ethnic, it's clearly that a type volunteer or participant have reached a very high level of Ripuronine. If I remember correctly, maybe 30% higher, and the viral load success is also more than 90% compared to the non-Thai. So and we have done another, we call the LASA study, looking at the lower dose of Ethnicity in the Thai population, because the average body weight in Thai population is smaller than in Europe and in US. So I think body weight is really matter if you deal with this.
Can I ask you, Kiat, do you see with antiretroviral therapy more toxicity in a Thai population than perhaps than we do because of the lower body weight?
That's a very good question. I think in terms of, we have done the LASA study comparing the standard dose of Ethnicity boosted 300-100 versus the 200-100 Ethnicity. It's clearly that is the percentage of people who have jaundice, rashes is higher than the historic report in the literature. And we lower the dose to 200-100. Yes, we see it. And equivalent if we taking care of a very small body weight Thai lady, like the body weight is less than 45, you start seeing a lot of CNS issues. So, so I think, yeah, it's not really a genetics, but I think it's really a body weight issue. When we reduce the dose into 1/3, and the viral load remain controlled very well, and then she very well tolerate on that. But of course, right now we have more option to switch, to Ripivirine is very wonderful, friendly in NRTI, yeah. and yeah, that's what we have seen. Okay, anything else that we want to address? I just hope that any question from the audience, please send us a note, and our coordinator will send it to her. Okay, there's no question from the participant. I think maybe let me ask each of the speaker that, do you have any specific, point to give to the audience that what I think Mark have done a wonderful, strong point that the best is to make sure that we select a regimen that effectively control the viral load, and then if they cannot tolerate, we can switch it later on accordingly. David and Opass, do you have any point to rest? A final message, please.
I think just briefly, I think Mark's point is the really important point, and also what you said, Kiat, in terms of efficacy. We've got such incredibly good drugs in terms of efficacy, and it's just the nuances of tolerability and just making sure that each patient does, and it's back to the individualization of therapy to make sure that we do that effectively.
Yeah, thank you.
For me, I think that, yeah, thank you. For me, I think that the subtype has no effect on the treatments, especially for those with just start the treatments. However, we need to monitor and we need to collect the data from small number of patients who fail in the different subtype, because most of the trial that conduct in for the drug discovery, they usually enroll subtype B, whereas more than non-subtype B. So we need to collect more data. Right now, I think there is no compelling evidence show that there is difference in terms of the treatment response among the subtype. The key is you need to monitor the patient wisely. You need to keep an eye on viral load in patients who have the risk for failure. For example, those with low CD4 or high baseline viral load.
All right, I'd like to really adjourn this lab table discussion. I really appreciate your contribution, all the three speakers, and thank to all the audience that's still staying with us online. I saw many, maybe up to 100 right now. Thank you very much. And don't forget that at 3:45 Bangkok times, we have the last session, clinical management in the near future. So please, stay tuned, and for meeting the expert, Opass is 5:10 Bangkok time. Thank you very much. Thank you all.
Thanks.
Bye now.
Thank you.
Bye. Bye, David. Bye, Mark and Opass. Thank you very much.
Thanks.